Okay, thank you, Lucy. I love the ending with your dog. It's amazing. Let's see if I can figure out how to get this in presenter view. And all right, so just full disclosure, before this, I had never treated BDD, didn't know a lot about it, had bought some books before I learned I-CBT and was going to dig into it. Can everybody hear me okay? You can, yeah. So had bought some books and I started learning I-CBT and dug into that. And I got a client right prior to that who I recognized had BDD. So I'm going to talk to you about her. Um, First of all, she came to me after she was in the hospital for 10 days with suicidal ideation and self-harm. Her mother worked with one of my clients and had told her about what she was going through. And my client said, "Well, you need to, try this counselor," and referred her to me. And she was diagnosed with major depressive disorder, recurrent severe social anxiety disorder, motor tic disorder. Sorry, tic is misspelled. And panic disorder. She When she was in the hospital, she also has selective mutism. She never actually spoke to the psychiatrist. I mean, she saw him, but she could not speak when she saw him. She had past medication was Prozac and Lexapro. Currently, she's on Zoloft, Seroquel, Clonidine, and has Ativan PRN, which she doesn't take. Prior to seeing me, between the ages of 13 and 15, she saw 3 different therapists, all of whom she said either she didn't like them, they weren't helping, but basically she just started refusing to go to each one. And they were good therapists. I know some of them, but they didn't recognize the disorders. So, the the symptoms that I don't know, my spidey sense went up when I talked to her, and I thought this is looking a lot like OCD. She had never self-disclosed that in middle school she started having intrusive thoughts related to harming self and others, some sexually perverse, forbidden thoughts, and perfectionism, which I'd sent her some assessments and she endorsed those items. She was having body focused obsessions regarding her nose, her arms, and being just generally being ugly. She was socially withdrawn from her friends at school, and even at home, she would stay in her room most of the time. Extreme anxiety with panic attacks, motor tics, her head twitching, blinking, shoulder shrugging, and that was near constant for our first 4 months of therapy. Broken sleep, waking up every 2 hours during the night. She was self-harming. She started self-harming in middle school with the intrusive thoughts. And I call them intrusive thoughts because that's what I called them when we started, because I didn't know ICBT to say obsessional doubts. But she would hit her head to try to punish herself, and later began cutting. But it was always the function of the self-mutilation, and the hitting was for punishment. And anytime she made a mistake or a perceived mistake, she would feel this urge to hurt herself. Fear of being judged and talked about by others, frequent crying spells, and selective mutism. So that's what I was seeing when I met her. Social history. Her mother and father were 18 years old when she was born. Mom says developmental milestone should be one word, within normal limits. Her mother describes her as just a complete joy in elementary school. She said she was a little shy. She struggled a little bit in school, but made average to above average grades. Was girly and active and just a happy kid. No history of trauma, neglect, or abuse, but mom says she changed almost overnight in middle school. Now, she did disclose to me that she had a friend in middle school who seemed to be pretty toxic. No bullying, so to speak, about how she looked or anything, but the friend would be really manipulative, ask her to do something. If she didn't want to do it, she'd threaten to kill herself. And for somebody who's already having intrusive thoughts about harm and self-harm, that was probably very triggering for her, and she experienced that as traumatic. We suspect her BDD began around 8th grade, and interesting, that coincided with COVID. You know, March 13th of her 8th grade year, everybody went into isolation and had to wear masks everywhere, which was probably maybe a relief, or maybe that's what triggered it. I'm not quite sure. So the assessment process was excruciating. It lasted 3 months. And because we were having to do a lot of grounding, a lot of sessions, she would just end up getting so anxious that she had we had to end the session early because she just literally could not speak anymore. Her tics were so bad. Her mother actually sent me a video of her that my client had sent to her mother because she was constantly texting and calling her mother to come get her or trying to tell her how bad she was. But in the video, it's just a constant tick. And it was a reminder to me, because she sent it to me recently, how bad her tics were when I met her. It's hard to remember now how bad they were, but it was constant. Eye blinking, head twitching. But I diagnosed her with obsessive compulsive disorder and body dysmorphic disorder. And kind of as a side to that, she had social anxiety. By the time we got finished with the assessment, her depression was mild, not severe anymore. And I think probably just because she had found someone who kind of understood what she was going through, who diagnosed her correctly, and started to feel some hope that maybe she could get better. And then the motor tic disorder, which at the time I wasn't positive if it was if they were compulsions or motor tics, but if I mentioned motor tics when she was in session with me to even try to assess it, they were off the chart. She couldn't talk anymore. She had them so bad. Now the compulsive behaviors, I've added the stuff, the reassurance seeking. She didn't do that for her body dysmorphic disorder. She was more avoidant with that, but she got a lot of reassurance seeking from other things. But this client had a uniform that she wore every day. Basically, it was a pair of baggy blue jeans and a hoodie 24/7, 365 days a year. She wore that hoodie and those blue jeans, no matter how hot it is. And we live in Georgia in the South. A lot of self monitoring of how she looked or how she perceived she looked, comparing herself to others. And this is OCD, reading and rereading, which was causing her a lot of problems in school. But even at home, like I said, staying in her room and a lot of mental rumination. So, and if you could imagine, she had to, like Lucy was saying, we're doing Zoom, and I didn't mention this, but she wore her mask all the way up until June with me. So we started in November, and actually in May she took it off a couple of times, but kept her mask on during virtual telehealth. And I always told her from the beginning, I know I know you're getting better when you show up without a mask on. And we kind of joked about that, but she kept it on. So after the assessment, these are her scores. This is one client that I did some really good testing on pre-assessment. And so it's a good client to present, but I used the Y-box too. She had a score of 36 at admission because it was 3 months before we actually got to the severity scale. I had her go back and rate where she was from the beginning. By March 9th, we started I-CBT on March 15th. By March 9th, she was down to a 19. These may be underestimations. The inferential confusion questionnaire, she scored a 130. The obsessional beliefs questionnaire, 170. I use the AAI now when I'm using the Y-box BDD, but I have a computer program that'll give me charts and graphs for the appearance anxiety inventory. And she scored a 33, which is at the 84th percentile for appearance anxiety, which correlates, and it's with the Y-box BDD. I did a perfectionistic cognitions inventory. This is based on a norm scale. So she was at the 89th percentile. She scored a 94. Frost multidimensional perfection scale at the 99th percentile. Social phobia scale at the 99.3 percentile. Social interaction and anxiety scale. So for social interaction, it was the 96th percentile, and anxiety scale, the 99th percentile. So we got to module 1, and her and keep in mind, we were doing I-CBT for BDD, for OCD, and I was just modifying. I was really winging it. I mean, Frederick had said, yeah, it's evidence-based for BDD, and it really happened pretty organically because these are the thoughts she brought up. But just for the purpose of this presentation, I'm only presenting the ones that are related to BDD. But, one is that she was really focused on her baggy jeans, even though that's what she wore every day. And her focus was the crease that occurred at the top of the legs and the back of her jeans. So she would wear leggings under her jeans. She was constantly straightening them, monitoring the way she walked. And she's even videotaped herself when she was walking to see how that crease looked. So you can imagine walking down the hall and constantly be worried about this crease at the top of your jeans. She worried about her arms looking funny, so she would sit with her arms together in between her legs and always wear a hoodie. The My nose is downward pointing, and this was an interesting, the consequences, like, and I think this is pretty obvious too for other people, is people will think I'm ugly and don't deserve to go to cool places. So there's a bookstore here that's kind of cool, an old retro bookstore that she said she remembers walking by and thought, I can't go in there. I'm not cool enough. I'm too ugly to go in there. And so she wouldn't go. She'd wear a mask even when she didn't have to. Look in the mirror, avoid going anywhere cool because of her downward pointy nose. And then one of the saddest ones is my mom thinks I'm ugly. And for that, as she said, I asked what the consequence. So she'll be disappointed that I'm her kid. She'll judge me and talk bad about me to others. So whenever her mom looked at she would tell her mom not to look at her. She would cover her face around her mom. She would stay in her room. And one of her mom's, things was like, we used to go places and have fun together. And she never wants to go anywhere with me. And I can imagine now, her mom had no idea she was having intrusive thoughts. She had no idea that she thought that she was ugly. And I didn't mention when I met this person, she had shaved her head. She shaved her head. She wore a mask. She was constantly ticking. So her appearance was kind of striking when you saw her. She actually started letting her hair grow out pretty early in therapy, way before we even started interventions. But we got to module 2, and she picked the thought that she had been obsessing about lately is my nose being downward pointing. Now, I had the ICBT for OCD modules, but for the purpose of this, I went ahead and applied her reasons to the BDD logic, which is common sense, hearsay, personal experience, the authority, and logical calculation. So she said teenagers can be a-holes. In 8th grade, I heard kids making fun of someone's nose. I could just imagine that's when it started. When I compare my nose to others, it looks downward pointy. It feels like other people are looking at me and judging me. Noses should point up, and a lot of people get nose jobs because they don't like the way their nose looks. We were able to accomplish this in one session. The obsessional module 1 took 3 sessions to get through. We got through this one pretty quickly, and then we went to module 3. And I'm going to show you in a minute, but we're seeing progress the entire time we're doing this. She's doing things that I'd never asked her to do. We're just working through the modules, and she's just challenging herself and starting to do things differently. So we get to the module 3, the BDD story, which we wrote several, but these are the ones related to BDD. And she says, I believe people don't like me and will judge me because my nose is too downward pointy. When I look in the mirror, it looks downward pointy. I compare my nose to others and mine looks different. I know people talk about other people's facial features because I've heard them and I have too. When I smile, it points down even more, so I try not to smile. Noses should point up. There are a lot of people who don't like their nose and they get nose jobs to fix them. And then her non-BDD, I was really impressed with her non-BDD story early on. She wrote, my nose is perfectly fine. People are not judging me because I've never heard anyone talk about my nose. Kids are mean in middle school because they are feeling self-conscious and about themselves and talk about others to draw the attention away from themselves. I have never heard anyone talk about someone like that in high school. I have no reason to believe that people are paying that much attention to me. I stopped wearing baggy pants and started wearing skinny jeans, and no one even noticed. So this was after module 1 on her own. She just wore skinny jeans to school. And it was a huge revelation that nobody even paid attention, that now she wasn't wearing her uniform anymore. It is just a nose, and they come in all shapes and sizes. It is not that important how my nose looks to other people. So we get to Module 4, which is the vulnerable self theme, and she identified, I'm a person who could be seen as annoying and not fun to be around. Really nothing related to the PDD at that point. But you'll see with the time chart, after Module 1, that was when she wore the skinny jeans to school. She was resisting rereading texts. She was starting to, you know, she showed up at one session with all these cool crafts that she had made, pottery and things, showing me the things that she had done. Was really excited that she had gotten back to doing things that she had enjoyed, and that she was taking her mask down more frequently. Now, this did not go fluidly, like no problems, because on this first session in module 1 was the first session. When we got to the quiz portion, she missed 2 answers. And we had to end the session early because she could not speak anymore after missing those. So at that point, I just stopped asking her to answer the quiz questions and just went over and gave the answers.
So we go through modules 5 through 9 or 4 through 8, and she's continuing to make progress. I'm still not. She shows up every session doing something different. Matter of fact, she during that point she talks about getting a belly button ring and actually gets a belly button ring, and then she gets a she talks about wanting a nose ring, and I'm like, whoa, what's going on? So we get to module 9, and the first part of this is a repeat of her BDD, her non-BDD story, but she adds to it. It's just a nose, and they come in all shapes and sizes. It's not that important how my nose looks to other people. My nose shape makes me unique. I've seen people online say they want a nose similar to mine. I've never paid enough attention to anyone I'm not friends with to know what their nose looks like off the top of my head. Everyone has their own insecurities, and no one pays that much attention to anyone by themselves but themselves. At this point, what I didn't say, and I don't know how to go back because I'm on my laptop, but at this point, at module 8, it was June 14th, and I took a month vacation. I was gone a month, and she was gone, so I didn't see her for an entire month. And so when you see somebody dated, week to week, you get all these subtle differences that aren't that stark to you. But when I came back on July 12th, or she was a totally different person. Her hair had grown out. Her mother had sent me pictures of her tubing down the river in a bathing suit and a two-piece. She got a nose ring, guys. Her obsession was her nose was a downward pointing nose. She had gotten a nose ring, and it just blew me away. I had not recognized the differences in her motor tics between, but they were gone when she came back. She made it through an entire session without having any tics. And the transformation of this person, if you had met her the day I met her, if I'd met her and then just showed up and met her 9 months later, I wouldn't recognize her. She was a totally different person. She was wearing makeup. She was wearing whatever clothes she wanted. She wasn't worried about her nose at all anymore. And I say that all to say, I've watched all of these videos. I've done all of this training, trying to prepare for today. And I just hear, all the different procedures you have to go through, all the different exposures and response prevention. And never, not once did I say, get a nose ring, or why don't you wear some makeup, or do this or do that, or don't. We did talk about social skills and different things, externalizing behaviors. And that was early on. But once we started, it happened so organically. I really was in shock and have spent about a month trying to figure out how did it happen. And I missed all of what Frederick said about how it happened, but I've kind of put the pieces together. She just had that cognitive shift that changed everything, and then started acting in accordance with her new beliefs. So the knowing absolutely came before the doing, but it was a wonderful process to see. So on July 12th was when we saw each other after our month break. And, her mother was over the moon. She said, I've had my daughter back. She just couldn't believe it. And she was by July 26th, we're getting ready to go back to school again. And she's really nervous, but she's making plans. She's excited. She's like, all last year I was obsessing all the time. I couldn't focus. I would cheat because I wouldn't, be able to study and copy answers and get homework for other people. So she had all these plans of how this year was going to be different. In June, she started practicing swim, started taking swim lessons, because her intention is to join the swim team, to try out for the swim team, which is what she's doing now. And by August 2nd, she had maintained all the gains she had made. And again, she went back to school that week, and she said, she had some triggers, but she was able to stay out of the bubble, recognize, it was OCD, or if she went in the bubble, she was just coming out a lot quicker, because we're dealing with several things. Interesting enough, the intrusive thoughts related to harming others and self, those resolved themselves pretty much on their own. And the sexually intrusive, once she realized they weren't her, there was a disorder, we just really didn't have to address those very much. Most of what was left by the time we got to treatment was the social anxiety and the BDD. So here are her scores, which are pretty dramatic. Her Y-box went to mild. That was on June 14th. I'm going to repeat it again next week. It may be even lower than that. Her ICQ, and Frederick, in the research study on BDD and ICBT talks about the ICQ scores not reducing dramatically, and there's some reasoning behind that. But the OBQ scores went from 170 to 71. The perfectionism went from, there's 3 subscales. The perfectionism went from 89 to 23. It was just amazing. Her appearance anxiety inventory went from an 84 percentile to a 0.5 percentile. I mean, Frederick, ICBT has changed the trajectory of this person's life. Truly, I can't imagine what what her life would have been like had she not this treatment had not been accessible to her. So again, her perfectionism is gone from 89 to 5%, 99 to 45%. Her social phobia went from the 99 to 52. That's not a normative sample. So that social phobia for a normal group, for a social phobia group, it went from 98 to 5.9. Social interaction went from 96 to 1.2, and the anxiety scale on that went from 99 to 42. Again, a normative. So she's like normal anxiety from a group. And social avoidance and distress scale went from 26 to 11. Anything under 12, over 12 is high. So hers is 11. So she's at 96 and 49. This was from March to August. And she actually had to cancel some sessions early on because she was too anxious. Something happened at school that got her riled up. So we didn't have every session, and a month off. This week when I saw her, she told me she was staying out of the bubble 100%. Last year when she went to band, she had to have the band teacher meet her outside of band, outside of classes. She could do the scales. She did the scales in front of her band class. She volunteered to read in front of her class. I didn't mention this, but they had made accommodations for her to eat in the media room. So, because she didn't want to take her mask down, and she's eating in the cafeteria without a mask. She asked a person she's been wanting to get to know if she could sit at her lunch table with her. She's staying organized with her school and her work and taking really good notes and studying them. And I said, "Is this perfectionism?" And she said, No. I'm just taking really good notes and keeping up with my schoolwork. So that's not." And she recognizes, no, it's not a perfectionism. She said, "I don't say I'm sorry anymore." That was constant. I mean, 50 times during a session, it was, "I'm sorry," because she couldn't finish a sentence. And then we talked about, I had brought up, several weeks ago that we probably were going to slow down therapy some because she was doing so well. And her eyes got big and she got really scared. And I said, "I think you're going to be so busy. You're not going to have time for me." And so at this session, she said, I think I'm ready to go to twice monthly. So it was, I just could almost cry when I think about it. I've been high all week after this session because just to see this person change so much in so short of a time, it was really an amazing process. And so basically, if you like treating OCD with ICBT, treating BDD it's become my new passion now. And I've had this, I've treated 3 people successfully. I've got 8 more that we're getting into it. But another client that I treated had a very, very similar response. And we've already gone to transitioning to once monthly with her. It was so quick, and it really seemed to be modules 1 through 4 that really the biggest changes occurred.
I mean, what a great presentation, both from Lucy and also this case study with this. And you can sort of see like how devastating BDD is as a disorder, right? I mean, OCD is devastating for many people, but BDD is just the whole shame and the social aspect starts to come in even more strongly with, and especially with kids, and when it starts that young. So in a way, I think part of the reason why I-CBT it's sort of a good match for BDD as well is because I-CBT was originally developed for OCD with overwide ideation. So not even so much a doubt, more like a belief, a delusional belief to some extent. And you see that especially in BDD, where level of insight is often quite low, conviction level starts to approach that in most situations, that of a delusional conviction, which can be difficult to penetrate, but also can result in people often not being very eager to go into treatment because of the shame on the one hand, but also Just talking about it is already quite difficult for people with BDD, but also because there's this conviction, they don't really believe it can be helped, because they believe so much in the fact that there is something wrong with their appearance. I-CBT addresses that initial thought, really, like, I am ugly. And I think even in general CBT they do. I mean Sabine Wilhelm wouldn't say this is just an intrusive thought, you know. She would say, like, okay, no, you have to address this idea, this initial idea as well of I'm ugly, not just the consequences. Like, that's in the generally the case in OCD, right? Where they say don't address the intrusion, just the appraisal of it, you know. I think in BDD that whole conceptualization falls apart, because you have to address the initial idea. And in BDD, it's not so much a doubt, it's more like a belief. And it's especially self-evident that initial idea needs to be addressed. You cannot ignore this idea. It's actually part of the whole definition of BDD. If you look at DSM-5, what defines BDD? It's like it's an imagined defect or a very slight defect. They have sort of like this quantifier. It can be very slight, but highly exaggerated. There's definitely a delusional aspect to it. And I think that that in itself makes it for a good match, because I-CBT specifically addresses the imagination and the fact that these ideas, whether it's obsessional doubts or a delusional, in the case of an idea about appearance, it's based in the imagination, not in reality, not in real perception, and not in sensory, in normal sensory processing.
I can ask, hopefully it'll just be quick comment. I'm also treating a teenager for body dysmorphic disorder. The difference that's something that's been kind of on my mind about it is just the criteria in the DSM being that it's a perceived flaw is so subjective. So I have this teenager who lives in a bigger body. So socially, she is perceived to be, she believes that her peers, perceive her as less attractive because of her bigger body size. So it's a very real thing for her that she gets a lot of reinforcement through media and through things that she hears her peers say. And yet, for me approaching it, I'm trying to be I am treating it as body dysmorphic disorder because it affects her life so negatively. And I am treating it as an imagined flaw in the service of being inclusive of a variety of body types, right? And so I guess I wanted to throw that out there. And if anybody else also struggles with that, like,
yeah, I struggle with, like, when I'm treating, because I try to tease apart, like, so, because I mean, fat phobia is a really real thing, and like diet culture and all of these, like, what is body image, what is an eating disorder, what is BDD, and with a lot of people, I mean, I get kind of start overthinking, like, when someone's talking to me about like size, not a feature, but about like body shape. I sometimes struggle with, like, I don't know if that's why I would treat that as BDD.
Yeah. Lucy, you want to answer that, or you want me to comment on it?
I mean, I run into the same thing with a client I'm going through right now. I mean, I think technically that might be an eating disorder. I mean, but I mean, in my mind, I-CBT is useful still because of the level of distress about exactly what you're saying. It's like, because some people are in bigger bodies and are just fine with it, or they don't like it, but they're not distressed to that level, or they're not doing repetitive kinds of behaviors or avoidance, that kind of thing. So I tend to think of that as, whether it's eating disorder technically or BDD or OCD, it seems like I-CBT would be useful.
I think, obviously, I mean, body image disturbances that you see across a lot of different disorders, eating disorders, like Lucy said. At what point is this BDD, or when is this an eating disorder, or when is it just in sort of like preoccupation with one's appearance. I think that's probably highly prevalent in probably more than 50% at one point lifetime prevalence. You know, just as we're growing up and we can get preoccupied with our appearance. Entirely normal. At what point becomes that a BDD? At what point does that become a body image disturbance? I mean, on the one hand, there's sort of like this continuum idea. When it gets stronger and more severe, then we can start calling it a disorder of some kind. I think what's unique to BDD, and to differentiate it a little bit from other disorders, I would apply the same as how we differentiate OCD from other anxiety disorders, which just means that there's clearly something else, and I think that's in generally how BDD is conceptualized. There is clearly something else going on than just an exaggerated fear of how you look. There's something happening out of context where, for some reason, it doesn't match reality anymore. And that's sort of characteristics of BDD. I mean, you can see that when you start guessing, person, you know, they're coming in with BDD and start guessing what they have. Don't guess, because it will never be what you think it is. You know, the person may have a big nose, but they have a obsession or a delusion about something entirely different, or a bodily preoccupation with something entirely different if it's BDD. So you have to be there. There is something, a mismatch with reality that goes beyond just an exaggeration of any flaw that somebody may have to some extent. You know, you see the same thing in OCD. It's the out of context occurrence of the obsession. It's not just an exaggerated fear of a possibility that something bad may happen in OCD. There's a mismatch with reality. There's a reasoning behind it that's sort of like creates this story about there being something wrong with me, or in the case of OCD, there's a problem of some kind that is not based on reality, that circumvents realities to an important extent, that sort of bends reality in order to make it fit by bringing all kinds of irrelevant associations, by bringing all kinds of histories in that but are not really directly relevant for what is there in the here and now. So that is how I would look at the difference, if that makes sense. Similar to how OCD is different from an anxiety disorder, so is BDD different because of that is really disconnected from reality. And you can get a feeling for that when you talk to somebody with BDD versus somebody who's just concerned with appearance. There's something else going on qualitatively, not just quantitatively.
Welcome back, ICBT friends and colleagues. It has been 9 months since we did the original training. And if you notice, it might look like some of the video is a little disjointed, and that's because it is. During that original training, my computer crashed a couple of times, and we had to do some splicing in the video to make it all seem a little bit more seamless. But we hesitated, or we paused to post the video online in order to give my client and her mother plenty of opportunity to change their mind in case they did not want her story to be presented. They have had the opportunity. They're perfectly fine. They have signed the consent forms and they're happy with it being posted. But before we post it, I wanted to give you an update of how she's doing. 9 months is a long time. And to give you a little bit of a snippet, she's currently packing for a trip to Europe with her high school, leaving tomorrow. And she's very excited, and I'm very excited to hear how that goes for her, and all about her adventures when she gets back. So I will say that when I presented in August, and it's now May, so it's been 9 months, she was doing great. It was the beginning of the school year. She had made a really, all of her transformation gelled over the summer. And now it was time to go back to school. She was feeling very confident, very optimistic. I was very optimistic. We decided it would be a good time to step back a little bit and start seeing each other twice a month. I felt like she was going to be too busy to be seeing me after school once a week. And she was in agreement. She was perfectly okay with that. So we went to twice a month. And what I did not anticipate, and learned a lot from this case, was what she still continued to need, the recovery after the recovery. Her scores on the Y box for OCD stayed low. They never spiked. Her scores on the appearance anxiety inventory for the body dysmorphic disorder stayed low. That never spiked. Those, she was in remission for those. But what happened was when she returned to school, she had a lot of catching up to do. Because remember, like I said in the previous video, she OCD hit about 6th grade. BDD hit it between 7th and 8th grade. So that means from 6th grade to 11th grade, she really had taken herself out of the scene. She had taken herself out of the social atmosphere. She wasn't going to dances. She wasn't going to games. She had a few friends, but she didn't go out very much. And so she missed a lot of important information and learning and growth in those developmental years between 6th grade and 11th grade. And when she returned to school, fully ready to engage and participate in everything that was there and available, she really had some learning to do. A lot of things, kids in the 6th grade act one way, kids in the 11th grade act another. They behave differently. They treat each other differently. She was getting her feelings hurt and really confused and shocked at the behavior she was seeing among her peers, where she just hadn't seen them before because she wasn't showing up. Things like going to a dance and everybody having really highly sexualized dance moves and twerking and all that, which we kind of accept as pretty normal for 11th graders. She hadn't been around that. So it took some adjusting and getting used to, some social skills. She was often very frustrated and getting her feelings hurt and expressing her emotions in a way she had not expressed before. And sometimes inappropriately, I would say, do you want to be crying that much at school? And she said, yes, I want to cry because I didn't cry before. I didn't let people know how I feel. And I don't want to close that down again. And, the idea was that it hurt her a lot to have to shut off her emotions for all those years. And she finally found her voice. She didn't want to shut it down. However, she wasn't expressing herself in quite the best way. So we had a lot of communication skills, social skills, and just getting over those humps. So between October and January, we went back to weekly sessions. We did a lot of hard work together, worked through a lot of cognitive distortions and social skills training. And by January, she was good to go. We went back to twice a month, and that's where we are now. She's been doing fabulous. I have her follow-up assessment scores. If she continues for the next 2 weeks to do as well as she has been with her OCD and her BDD, it will be a full year since she's been in remission, and we will consider her in recovery, which I fully expect that to happen.
Okay, and looking at her assessment results over the entire course of treatment, I'm going to pull up this chart. And her Y box 2 was a 36 right when we began working together. By June, after we had done 3 months of I-CBT, it had dropped to a mild. In January 2022, actually, that should be January 2023, it was a 2.5. So there was a 33.5 drop in score, which correlates with an 89% drop in her Y box score. Her inferential confusion questionnaire, the score was 130 in March of 2022. In August, it was a 98, which still was clinically significant. And I think about 92 is clinically significant, which was interesting because her Y box scores had dropped so much. By May of 2023, it was a 46. That's a drop in 84 points with a 64% reduction in her inferential confusion. Her obsessional beliefs questionnaire went from 170 to 45. That was from March to May of the next year, so 14 months. And it was a reduction in 73%. Now, when I worked with her in the beginning, I was really new to body dysmorphic disorder. And so I was using the appearance anxiety inventory, which measures progress over time really well. And in January of 22, her score was 84%. Her BDD score was 84%. In August of 22, it was 0.5%. That was after 3 months of treatment with ICBT. In November of 22, it continues to drop 0.2%. And there was an 83.8% difference and a 99% reduction in her body dysmorphic disorder overall, which she continues to maintain that progress that she made then. BDD and OCD are not at all ever even discussed. I did ask her the other day if she ever had thoughts like she used to have with her OCD. She said every once in a while they'll pop in and she just laughs at them, which I thought was pretty cool. So now the other scores that I tracked all along was because she had a lot of perfectionism, which shows up a lot for BDD. And you can see that her perfectionistic cognitions inventory went from 89.8% to 5%. Her Frost multidimensional perfectionism scale went from 99.6 to 6.6. I mean, those are huge drops. Less than the average population. Her social phobia scale, this is really interesting. This measures social phobia and anxiety. It went from 99% to 52%. And then remember, I told you, when she started back to school, she started having some problems with social situations, friends. So it rose again to 69.1%. And then by May, everything worked itself out and she was at 1.2% on the social phobia scale. On the social interaction and anxiety scale, basically the same thing happened. So this is measuring social interaction and anxiety. It was 96% for social interaction. It dropped in August to 1.2, rose a little bit to 1.8. In May, it was 0.3. The second score is about anxiety, 99%, 42%, 46%. Again, that was a really rough time. And then just a couple of weeks ago, it was down to 29.2%. Social avoidance and distress scale went from 96%, 49%. Again, there was a blip, a rise in score in November, and then back down to 30% in a couple of weeks ago. So overall, she has maintained her progress. Like I said, if she continues to maintain her progress for the next couple of weeks, which I assume she will, we will consider her in recovery from OCD and BDD. And she has been an absolute pleasure to work with, a joy. I think she's a great person and she has a lot to offer this world. So I look forward to seeing what she does in the future. Thank you so much for listening to this training, and I hope you learned something that will help you with your clients or give you some motivation or encouragement to try I-CBT for BDD or OCD. Thank you.